Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller, and today we have a very special guest, Dr. Lauren Juyia. Welcome to the podcast.
Thank you. Glad to be here.
Yeah, I'm so glad to connect with you this way, and also because I give you lots of patience. So hopefully we can have a wonderful conversation today. So why don't you tell us a little bit about who you are and what you do?
Sure. I am an OB-GYN board certified. I graduated in 2015 from my program in Albany, New York. I now have a private GYN only practice based out of the kind of northwestern suburbs of Tampa in Clearwater, Brooksville, Wesley Chapel. Primarily, I have one partner, a wonderful nurse practitioner. Dr. Reller does make us very busy at our Clearwater location, which is wonderful. So, like I said, I've been in practice for 10 years. I'm 40 now. I have two small kids, a husband, like a really typical, joyful life, busy with little school agers. 3 years ago, I was diagnosed with stage 4 colon cancer. So I also try to not only practice as a GYN, but bring awareness to colon cancer in my region and in the world. Colon cancer screening has been always something, screening in general, really important to me. I'm even more effective now getting my patients to keep up with their colon cancer screening or to have their GI symptoms evaluated, because it so often goes hand in hand with endometriosis and pelvic pain. So kind of two big missions: is good GYN care, and listening to patients, but also helping people to get their screening that they might be hesitant or not aware of that they're eligible for.
Yeah, I mean, I know we were talking before recording, and I think your story is really amazing. And I don't know how rare, but maybe that's something you could share too. But if you are telling me you're only 40, you're clearly not eligible for typical colon cancer screening, which they did change the ages recently, right? So it used to be 50 and now it's 45, but you're not even there yet. So can you make a comment on that?
Yeah, so it's still too rare to be worth, for lack of a better term, screening everyone who's young that's not at risk. So screening did come down because it is a cancer that's starting earlier and earlier. Screening now is to start at age 45, or for people with family history, it's often earlier. For me, there is no family history. We don't have cancer in my family. I don't have any risk factors. So sometimes it just happens. And I think sometimes a big part of my message to my patients and on my online presence as the benign GYN on Instagram is that you don't have to have risk factors to be at risk. We don't really understand why it's happening to young people anymore. We're not eligible for routine screening. So you have to be really diligent about any symptoms, even though they really might be something normal. It might just be some hemorrhoids bleeding, but even if it happens once or twice, it's really worth still offering that information to your doctor and finding out early if something is a problem versus if it's just fine. Because for me, at least, I was 37 when I was diagnosed with stage 4 colon cancer. And of the all the ironies, the only reason I found it is because it metastasized to my ovaries, which was what made me stage 4. And, as an OB-GYN, I am really familiar with what an ovarian mass is, what it could feel like. You see it enough times, you can feel it yourself. And I was able to get the imaging and the process and the surgery going really fast because of people I know and the awareness I have when it happened.
Mm-hmm. Yeah, I mean, I think what you're doing to educate everybody else, like to validate their symptoms, share them with their doctor, and, encourage getting screening or testing is so important. So I'm thankful that you're sharing that with us too. I know we weren't going to focus on colon cancer because we want to utilize your expertise in our GYN practice, and we wanted to talk a little bit about perimenopause, menopause, and hormone therapy. So I think what the other thing I was going to say was I love the Instagram handle. So we'll definitely share all that at the end, but it's perfect to help educate everybody as well. So why don't we kind of transition into the discussion at hand? So can you tell us like the difference or between perimenopause and menopause?
Yeah. So the simplest medicine is very simple because we have to make a definition. And I think this always surprises people, even though it sounds so basic. Menopause is literally 1 year, no period, with the asterisk of like on your own, right? We're not medicating it away, or we didn't remove your uterus. So we don't know when the bleeding stops on your own. And so everything before that is not menopause. Menopause is that one day when you've made it 1 year with no bleeding. After that, you are postmenopausal. And before that, if you're having any symptoms at all, or just your period cycles are shortening, are often the first sign of perimenopause. Everything is perimenopause.
Mm-hmm. Yeah, I think that's one of like the big confusions that some people have as well. Like, do you do anything with perimenopause? What kind of symptoms happen in perimenopause versus menopause? And I think one of the things you wanted to do today, especially, was like dispel any myths and just generalize, give good information about these conditions, if we call them conditions, these natural occurrences. Yeah. So how can women know if something is like normal or if there's something that they should talk to the doctor about with regarding, perimenopause?
Yeah. Well, I think if you're questioning it, it's worth asking because normal and common are two different things. And so if you just talk to your other friends, especially if they're of your same age, they might all have the same common symptom of maybe heavy bleeding, but that doesn't mean it's normal.
Right.
So it's really hard to go through and say what's normal, what's a spectrum of normal versus what's a problem. And sometimes that spectrum of normal might be a problem only for some people. So in general, talk to your doctor because things do change in perimenopause, and it might not be okay, but it might be something you're tolerating on accident, really.
Yeah, it might be, common or one of the signs or symptoms of it, but if it's something that's bothering you, it's definitely something to bring up, right? And even if, one person says, oh, my hot flashes are not a big deal, like maybe you're really getting impacted by that, right? What are some symptoms that women might experience during this time period?
So the classic things that happen are that your cycle length is going to shorten in perimenopause. And that's because we start running out of good eggs. All of this is happening around our fertility, which is ending essentially. And, there's different theories why this happens. I prefer to think that it's the grandmother theory because we're so important. Our knowledge needs to be preserved and we can't keep risking our lives to die in childbirth. Good data behind it. So the first thing we're going to notice is that our cycle lengths are shorter. If you were always a 28-day person from day 1 to day 1 of your bleeding, that might now become more like 21 days or 24 days. And bleeding patterns also change, meaning typically lighter, but sometimes they're much heavier or longer. And so now if you're a 7-day bleed person and some of those days are really heavy and your cycle length is only 21 days, you can see there's only 14 days you're not bleeding, and people can get into danger really fast, even though that's normal or so common and normal, big deal. I should say it's not normal to have that heavy of bleeding and to become anemic. So sometimes people just have symptoms of anemia because it creeps up on them. I think most people know of hot flashes being a big symptom of perimenopause. They don't have to happen all the time. They don't have to be, the classic sweating and all of a sudden. Some people just find that they feel hot or even cold because it's more about the temperature regulation being not as good in our brains because there's not as much estrogen around. Sometimes it's bigger PMS symptoms like bigger mood changes, bigger symptoms of cramping and breast tenderness, all because of these hormonal shifts that happen and that are bigger in our perimenopause. Sometimes anxiety worsens, ADHD, mood changes, irritability, libido, although it's not always, more commonly, I would say, not directly related to just menopause, libido goes down, but maybe all those other things are affecting that, and then that's our symptom.
So why are there so many like random symptoms that can occur or are associated with, menopause?
Yeah, I think it might not be so random, but
Mhm.
more that our knowledge of perimenopause and menopause is only just beginning to be good at explaining some of these things.
Mhm.
That maybe we're just lagging behind. We know that our hormonal shifts are bigger because our ovaries essentially have to be yelled at by our brain to ovulate. And so when they're being screamed at and they finally listen, sometimes they shoot off way too much estrogen. And then when you come down, if you're not, pregnant, those hormones like drop bigger to come down to the level of when you're going to have your period. And so that's part of it. Physiologically,
Mhm.
bigger shifts make bigger symptoms. Also, if you don't have as much estrogen floating around, because sometimes further or later into the menopause transition, you're going to have times where those ovaries are not doing anything. They're not listening at all. Lab work at this time will look totally postmenopausal, but someone is not because it's only been 4 months instead of 12 months with no period. So there's literally almost no hormone floating around, and our bodies aren't used to that yet. We're not used to functioning with very, very little estrogen. And so some people seem to adapt to this really easily, and other people don't. There was a really neat study within the past year showing that in in our brains, we make more receptors to catch that scanty bit of estrogen. And so we think maybe a lot of our body parts with estrogen receptors can do the same thing. And some people are faster at that than others. And so the people who are less efficient at using estrogen might have more of those weird, more miserable symptoms and mood changes and heart palpitations and joint aches.
Yeah, I was going to kind of bring up something similar where, the estrogen receptors are not just where we think they are, like ovaries and, the brain really. It's just we're finding that they're all over, right? And that's how when it's dropping, that you can experience a lot of these symptoms. So I think that makes sense. Now, why do you think our knowledge is so lacking in this area?
Well, I think a huge part of it, this is maybe getting more attention in our world than in the public's world, is that for so long, most studies are really for like 170-pound men, which is only half the population is born male anyway, and then most of them aren't even 170 pounds anymore. So a lot of our data just isn't going to be relevant for women. Women are classically understudied.
Right.
Menopause doesn't get a lot of attention. I think there's a really good argument in there about the inbuilt misogyny of our communities, of the research world, of medicine to ignore women, or that maybe our fertility years get more attention and our worth and value after menopause isn't noticed so much as it should be. So I think it's multifactorial why there's not a lot of interest previously. And finally, I think there's some traction gaining ground. The WHI got a lot of funding directed towards menopause research in the past couple of years. And Halle Berry was the face of that, which was pretty awesome. And then, that's been threatened to be compromised lately. So, there's still just maybe only a lot of hope that there will be continued good research in
Yeah.
this niche.
Yeah, I think you tackled the points that I was hoping that you would, so that, women are a little bit more understudied. And I think that seems to be perhaps changing according to, a lot of other people in this field, and people are getting the word out to make that it be important that women are studied, especially like in the workplace, right? As we work later on, I think even employers and things like that want to know how can they support you. And I don't know what I was listening or reading recently, but there was, some ways that they are trying to make it more supportive environment for women who are going through these changes that may need some, help at work and things like that. So I think we're going in the right direction, but I think, like you said, definitely understudied. So where can patients get some education on menopause and things like this? What do you
Yeah,
recommend?
always a great resource is going to be menopause.org. The Menopause Society, renamed from the North American Menopause Society, has really great data and recommendations based on data, but also great patient relevant information. Like, there's a lot of our jargon for physician level information and our guidelines here, but there's also really great stuff for patients themselves to learn to self-educate, to know what they want to ask for, to maybe understand better why we don't want to be starting hormones in somebody who's 70 years old and never on hormone therapy since menopause 20 years ago. There's a lot of information there. It's a great place to start. And then maybe, different learning style. A podcast I'm really into in this moment by two, there's no menopause school, right? But menopause experts, they're OB-GYNs, they do clinical research, and they're not selling anything, which I love, is a podcast called Ovary Active. Ovary like our organ, right? So
That's cute.
they go through a lot of the data. They're physicians as well. So they do kind of nerd out and laugh at themselves about that, because, don't get lost. They don't do it for long. It's just kind of fun. But then they also discuss a lot of the nuts and bolts of how things are going to apply and what you're going to notice in perimenopause.
Yeah, so definitely there are resources out there. You mentioned I think the Menopause Society, which is probably one of the best. So you also mentioned previously something about lab testing. So is it useful to test labs for diagnosing perimenopause and menopause? What do you do in your practice?
So I follow guidelines that, like I said, are evidence-based. They're reevaluated periodically. We're not falling behind and missing out by not using labs often. So there's a very, very rare time that they are applicable, but in general, if you've got a person that's the right age with symptoms, it's reasonable to assume it's menopause. And so I don't generally use hormone testing labs. Everyone wants to know, like, what's my estrogen, what's my FSH, my brain talking to my ovaries, what's my testosterone level, progesterone level. But a lot of those are going to be dependent day to day where you are at in your cycle or your not cycle. They're not diagnostic of anything. You cannot diagnose menopause. You can't diagnose perimenopause. It's more like excluding other things. If you have someone under 45, make sure that, it's not their thyroid making them hot, or their blood pressure is going up and down making them hot or cold or tired. So labs are useful under 45 to exclude other conditions that might mimic. If you have someone who's really young and it's not the typical time, like premature ovarian insufficiency, we call it now, early menopause under age 40, FSH being elevated at a certain time in a cycle can tell us, along with other labs, rule out other causes and say, yeah, this is the 1 in 10,000 menopause. But in general, it's about, are you having periods or not? And if you're not, that's post-menopause if it's been 12 months. So we know labs after menopause are going to be almost nothing. I tell my patients, no point in checking. If you're symptomatic, that's what we care about. If you're still having periods, those labs are going to be different every day of the month, where you're at in your cycle. So that's not helpful to me. If you're having symptoms and it's nothing else, we treat. It's really intuitive, and there's no goal level of estrogen. So I get asked that a lot, is I've been on estrogen now should we check? No. Are your symptoms handled? Yes. Okay, then we're at the right dose. And if your symptoms are not handled, we need to go up, or we need to think about something beyond estrogen being the cause. Sorry, this is such a long answer because there's more. And progesterone's role, it's not the workhorse. Estrogen is the workhorse that's going to treat these menopause symptoms really efficiently. Progesterone's use here is to protect the uterus lining from the estrogen. It's not a nice hormone, it's the PMS hormone. There is no optimizing it. We just need to protect the uterus lining. So it's dosed to protect from the estrogen, whatever that dose lands on, really. And it's a really interesting thing out in the community, advertisements for progesterone cream to fix everything from low progesterone, high estrogen, estrogen imbalance, mood. Estrogen cream's not well absorbed if it's natural estrogen. There's no goal level because if you're ovulating, it's going to fluctuate all over the place. And why give someone mood changes and hungriness? That's what progesterone really does if it's too high or not a form that you're tolerating.
And then the creams don't even protect the uterus, right?
No, they're unreliably absorbed, if at all. And so you do have the risk of endometrial cancer if you're underdosed with progesterone, but you're taking estrogen, which then I have patients that say, well, I love this yam cream I found over the counter and it's all I'm on. It's probably harmless, but it also might just be all placebo. So I don't change that if they feel that that's all they need. Mm-hmm. I do kind of poke around and say, well, what are the symptoms that you're trying to treat with this yam cream or over-the-counter progesterone? And let me know if they become not controlled or something that you want to treat with FDA-approved drugs that we have that are really effective, bioidentical, because that's a really good catchphrase right now, and really safe.
Mm-hmm. Yeah. So, I mean, you mentioned the bioidentical thing. Obviously, that's a big hot word, like you said, catchphrase. Can you just explain what that means?
Yeah, everything that we take is somehow synthesized if it's from a pill, right? So if it's a plant that came out of the ground and they processed it into a pill, it's still synthesized. So natural and bioidentical are more marketing terms in our world. I think maybe it's nice for the public to hear just because it sounds reassuring, but it doesn't mean there's no risk. And so everything should be discussed as a risk benefit discussion. And it just means that it's produced as similar as we can make it to what our bodies make when they were making that hormone.
Yeah. So who's a good candidate to start on hormonal therapy?
Yeah, a lot of people. It can be safely trialed with, right? So once you've done the work of making sure it's nothing else in people who are, not over 45 or there's other things going on, there's a cardiovascular risk calculator that we can use to make sure that someone doesn't have a high risk of heart disease, no history of uncontrolled hypertension, crazy cholesterol, relatively close to their menopause transition or in that transition. So not more than 10 years out without hormone in general. Ideal less than 5 years. Having obvious symptoms of menopause is always nice because it's really easy to objectively evaluate if our intervention's working. Everyone knows of hot flashes. That's a really easy way to say, how many are you having and is it more or less than it was? But people with sneakier, more insidious symptoms of mood changes and things, it can be worth a try and seeing if it helps for people that are relatively low risk, like I said, close to their menopause transition or in it without big cardiovascular or stroke risks. We don't worry anymore about family history of breast cancer. That used to be a strict contraindication to starting it. Obviously, the person needs to not have a hormonally receptive cancer themselves in their history.
Yeah. So what other risk benefits would they consider? Obviously, you mentioned the big ones right there.
Yeah. Generally, it's so low risk that I think for a lot of people in that menopause transition or early after menopause are safe to try it and see if symptoms respond. Because, are the mood symptoms just from menopause or is it that it's poor sleep from hot flashing at night that doesn't quite wake you up, and people try to wear their rings that check their pulse and their movement, all this stuff, but they're not necessarily a great predictor of what's really going on in your sleep. So sometimes I just like to try it for somebody who seems of the right age and is low risk, and see if it works, because it's so safe. It can be really effective, and better sleep can result in more daytime energy. It doesn't cause weight loss, but some people who feel better aren't all stressed out from bad sleep, from waking up a lot. Maybe it clinically lowers their cortisol levels a little bit. It's not, again, not worth measuring cortisol, because true pathology with cortisol is going to land you in the ICU. So this is just a normal response to having less sleep, more stress. And we know cortisol will increase our cravings for fast carbs, and we don't exercise as often if we're tired and stressed out. So it's this whole cascade where a lot of times it's worth just trying it. And it's really safe for most people.
Yeah, I mean, it's amazing how much better people will feel, just like getting the full night's sleep, whether it's interrupted by hot flashes or just poor sleep in general, and all those things that you mentioned that they're able to do during the day and not have, cravings and over hunger, and, you're able to work out. I mean, those are all like super important things to have a healthy lifestyle, right? So you're clearly going to have overall improved health if you're feeling good enough to take care of yourself. Yeah.
Yes.
Well, as you are, a survivor of cancer yourself, how do you evaluate and help patients who might be more resistant on doing that due to all the previous information about, does hormone therapy cause cancer, kind of thing?
So it doesn't really. And in some cases, it might even lower cancer risk. So, I like how you said putting yourself first. I think people forget they're allowed to not be miserable. And I remind them that line is theirs to draw. It's not mine. I'm not the one waking up 4 times a night. I'm not going to tolerate that. And I tell them, maybe I'm wimpy. Do whatever you want. But I'm here if you want to discuss it further. And I remind them of, what do we know of breast cancer risk? And again, this is where we're lacking in a lot of studies that are more recent. One of the biggest studies you're going to hear people refer to was that WHI study that first came out in 2002 with some results, and everyone freaked out about this breast cancer risk that was discussed ever since then. But really, a lot of it's misrepresentation. A lot of those women were remote from menopause, meaning over 10 years. They were in their 60s. They were using horse estrogen, not the estradiol bioidentical one that we use now. They were using an old synthetic progestogen form of progesterone that we generally don't use anymore in our hormone therapy. We use natural progesterone because it does have a safer profile. And so in those women, we saw a 1% increased risk of breast cancer. And we did not see any increased risk of breast cancer in the people on horse estrogen alone. So we know estrogen alone does not cause cancer. People with a uterus have to be on a progesterone, or we will cause cancer in that uterus. And when we use not that old synthetic progestogen, we're not seeing a cancer risk. I would never say 0% risk to my patients. So I generally just tell them we know it's less than that 1% increased risk of a cancer that we have really good screening for, and that we all have a risk for anyway by having breast tissue. Mm-hmm. And then we know endometrial cancer, when there's appropriate amount of progesterone on board, is the same whether or not you're on hormone therapy. And colon cancer is actually less with estrogen. So all the more reason to consider it for some people.
Yeah, I mean, the Women's Health Initiative, like you were saying, kind of led people astray. And I think it's because it was publicized that it was causing cancer, and they didn't decipher all the different things that you've mentioned. Yeah, which I think is super important. I was even talking to a breast radiologist last night, and he was saying, well, he loves his job because not only is it, helping patients, but breast cancer is so curable too. Not a reason to go, increase your risk factors in getting it or anything, but like, that's why he's, pretty happy with his position, is that it's very curable. So, and it's like you said, there's good screening for it too. So, as long as you're keeping up with screening and things like that, I think that people can feel pretty safe using these things, even though the risk is really, really minimal anyway. Yeah.
Agree. Yeah. And we know this. Screening is a mammogram. It's not a thermogram. It's not ultrasound. Ultrasound's an adjunct. Thermogram is not helpful. It can be MRI for higher risk people, but generally it's a mammogram yearly.
Mm-hmm. Yes, I know there's a lot of other modalities that are coming out or available, but yes, mammogram is the still gold standard of screening. Depending upon, like you said, for higher risk, there may be the MRI usage, but obviously you're not going to do that in everyone because it's expensive too, but saving it for the right candidates as well. Yeah. So I know there's other like non-hormonal treatments and things like that, but we were more focusing on the hormonal therapy. Is there any other things that you want to discuss with regarding to everything?
So I would love to, there's so much. I guess I feel like it's distinct in my head and then I get really pumped about all of it. So I like stop me literally. Okay. Bioidentical, like I said, it's really a marketing term. We have lots of FDA-approved formulations of estrogen that are really, really safe, generally very affordable, covered by insurance because they are so safe and tried and true. And we have something that will fit everybody somehow, right? So FDA-approved forms are going to be pills, patches, a gel daily. The patches are twice a week or once a week, but the once a week ones are really big and they fall off. So everyone uses the twice a week.
Let me make a comment on that. I did not know how big the patch was, and a patient showed me the other day, and it is so tiny that like I have contact dermatitis and was concerned one day if I was going to use this. I'm like, oh my goodness, is it going to make me itch? And is it going to be huge? But it is so tiny. I'm trying to think of a size. What would you ache into the size?
Not much bigger than a quarter, really.
Yeah, no, and I mean even smaller than that, really, but. It was just surprising to me. So I learned something new the other day, that it's super tiny and you obviously can rotate the site and everything like that too. So
people forget, because I have the same realizations all the time too. Like, we prescribe this stuff, but I don't see it in real life unless I use it myself.
Yeah.
And there's been some interesting lessons there because I never took any medicine except birth control until I had my cancer, right? So I've had a huge experience now with these funny gaps in knowledge that's like I didn't even know was there. The patches and pills, and for me during my cancer treatments, Zofran is the ones that dissolve on your tongue. They're so disgusting. There's like 4 brands that are really, really gross, and one maker that makes it minty instead of this sweet gummy bear, I don't know. And it was just so terribly triggering for me when I was on chemo for a year. And I didn't know that maybe I'm making my patients miserable with the treatment itself, or that can become triggering, or that the patches are small or the big ones fall off until my patients showed me. There's a vaginal ring. That one, for most of my patients, is cost prohibitive. It turns out to be like, even though it's convenient, it's once every 3 months, it just sits there. It's usually around $600 for 3 months is what people tell me. So I don't have anyone really using that, but a couple people. There's a nasal spray that also, it's not cost prohibitive for some people, like $70 a month is what I'm told, but it's so much more pricey than the patches, the gel, or the pills. So those are going to be your trio of common estrogens that we use. And as really well stated by the Menopause Society, compounded hormones are to be used. They say it nicer than this, but it's basically an act of desperation. Like, if you can't find one of these well-formulated, bioidentical, FDA-approved, affordable formulations that a patient can tolerate and is a good dose, then that's when you go compounded. And so far, in my 10 years as an OB-GYN, And now, like I said, 7 years doing GYN only almost, I haven't had to compound anything ever. Like it is an act of desperation. And I have not yet been there despite my hundreds of patients on hormone therapy, because it's a marketing thing. It's like, oh, you're so unique and so special that you need this bizarre formulation of really expensive compounded hormone therapy that may or may not be what we say it is every time you go and pick it up. And it's just not reality. Like, so far, I haven't found someone who needs that. And then even more extreme is the pellet. Pellets are not FDA approved. They're compounded, and then they're inserted. They're very expensive. It's a great cash cow for people who are offering these and who are not concerned about their patients' safety.
Yeah, I definitely see, over hormone stimulation from the pellets. And I totally agree. There's, affordable ways, insurance covered, and I've never needed to use the compounded either. But obviously I get lots of patients who are on them and I'm like, you're happy on it? Or what do you think? But sometimes I have a conversation, sometimes they're never going to change their mind anyway. But it's better to inform people prior to starting these things for sure as well. So,
right, which is the whole point of why it's great to have your podcast and this public information out there before people resort to pellets, because they are very sexy and well promoted. And I think doctors, we're not good at PR. We're like, here's our evidence-based medicine, and people think we're sticking all of these rules for no reason, and we don't have fancy terms that the public likes, like hormone balancing is not a medical term. So I neglect to use it, but that's what the public understands because that's what's promoted out there. And so then, we're not as sexy with our little patches, but we're more effective, we're safer, and really more honest and doable for people.
So one thing that some patients who go to other providers that are doing that are, they feel like they get heard and listened to more, right? And I think that's how they end up over there. So I think we need to do a better job, making sure that, hey, like you said, tell us your symptoms, right? And then explore the conversation further. And I think as a medical community, we can do better with that for sure.
So on that point, heard, and we can do a better job. Absolutely, I agree. And part of it is that genuinely, I do believe physicians are sometimes not listening, and that insurance construct makes it really difficult to have that 1 hour conversation that sometimes people really need because there's so much going on and then so much to counsel on and educate with, which is where that self-education at home might help a bit to shorten that discussion or heighten the understanding so that they know where we're going with things. But also, the way insurance is that people don't understand, and they really need to understand their insurance, is that when they come for their wellness, there's Well Woman and Wellness with You, that is a great time for us to be going over all kinds of wellness stuff that really does take all that time and screening. It is not designed to have that 1 hour discussion. And it's like the bane of every gynecologist's existence that I know of, because we keep trying to troubleshoot to give patients the time they need for a problem visit and distinctly different time for their wellness. My front office team has a whole script of how they ask, do you have any concerns you want to address at an appointment separate from your wellness? We make it clear what a wellness is. We have paperwork someone has to sign of my wellness visit. It covers this, and it does not cover problem discussion. And yet still, several times a day, people are shocked with how much we cannot address problems. And even though menopause is normal, the problems with it are not normal, and even though they're common. And so that really deserves its own discussion, and patients need to recognize and feel empowered to schedule as such. Give us the chance to go over stuff with them, because it's not fair. It's not apples to apples to say, well, I go to my pellet people and they listen to me for an hour. Well, yeah, but you told them you're going for a problem, not wellness. Yeah. And, you know, and so given the right situation with an aware patient and aware docs, I think we can be a much better team than we have been in the past.
Mm-hmm. No, I agree. There are definitely misconceptions with insurance and what is covered and what is not. And it really needs a dedicated appointment. I do the same thing for weight management. It needs a dedicated appointment, you know, and unfortunately, trying to let people use their insurance in an insurance world, those are the things that we need to do to really hear them out, to make the best plan for them is going to be at a dedicated visit to discuss it. And it is a little unfortunate, like when you're coming in for your well woman or well exam, that something normal like menopause is not part of it. But like you said, the things associated with it kind of put it outside what is covered in that visit. So I think that's a big distinction. Like you said, give us a chance to have that discussion. It just needs to be likely separate.
Yeah. Yeah. And like I said, I get really geeked out and really excited because there's so much teaching and empowerment that can happen at that discussion. And I jokingly tell my patients, one of my chief residents, my daughter's named after her. Back when I was a resident, one of my chiefs told me when I was kind of a useless first year, right? Like you don't know what you're doing. You're fledgling, you've got the background, but you still have to learn how to apply this all by yourself. And she said, I know I'm overwhelming you with information and with things to do, and I'm teaching you a lot, and it takes a lot of my time, but it's going to be worth it, because then when you're a second year, you're going to be great. You're going to be able to know what you need to do and know what you need to keep your patients safe. And so our first visit, because there's so much to go over, I tell my patients, I'm doing the same thing my chief did. I'm giving you all this information. I don't expect you to memorize, but I want it in the back of your head so you know we can tweak this. You're not stuck with that. There's other formulations, and you can tell me what's working or not along the way, because this time investment in you will pay off for you. And later we can make this perfect.
Yeah, I like that. That's a great, analogy to your own training.
Yeah.
Yeah. So where can people find you, work with you, or follow you, or how can we have them connect?
Yeah. So my online presence, like I said, there's a lot of GYN stuff, little topics. I try to make it really short and digestible, but also colon cancer education, or my journey, or just stuff I reflect on or see in the world. That's my Instagram is The Benign GYN. And also I'm on Facebook as Lauren Juyia, my name, Juyia. If you Google me, you'll find my offices, the Elite Women's Care here in the Tampa area. One office is in Clearwater that's moving to Tarpon soon. And also Brooksville, where I've been my whole career as an attendee. And also Wesley Chapel, where my partner practices.
Nice. Well, awesome. Is there any last final advice or words that you'd like to share?
Oh, get your screening. It is a privilege. It is available. There is nothing as good as a mammogram and a colonoscopy. And it's not that bad. I have lots of tips and tricks to make it not miserable. And talk to your doctor. Give them a chance to help you. Tell them what's really going on, and schedule accordingly so that there's time for everything to be addressed.
Awesome. Well, I love that last bit of advice. And thank you so much for joining me on the podcast today. I loved having you. This was a great conversation. And everybody tune in next week for next week's episode. And if you need a primary care or, allergy help, obesity medicine help, I'm in your area. And otherwise for GYN, you can look on the show notes for the information to work with Dr. Juyia. All right.
So much, Dr. Reller. Great to be here.